Um, I am tasked to discuss uh, about chapter 18 of the biopsychology of um, Pinel. And this chapter is about biopsychology of psychiatric disorder. So before we begin, let me consider these two important fundamental questions in order for us to be able to explore what are this psychiatric disorder in relation to brain circuitries and other neuro or chemical transmissions that affects somehow or associated somehow uh, with such disorder. So um, please try to consider that there are two important questions that we really have to think of. What are psychiatric disorders? How do they differ from the neuropsychological disorders, which you have learned in your what they call this in your chapter 10, which is the brain damage and neuroplasticity. So we'll try to associate or to connect these two important questions, whether there is any connections or any association, or if there's none with regards to psychiatric problem or psychiatric disorder. Now, allow me to present my PPT or PowerPoint for a while. And of course, my apology if I'm not going to have my video presentations. I will not be able to open my video while presenting the PPT because there might be possibilities that mag-lag. Okay. So anyway, so I'll be sharing this presentations together with my discussions about the important topics of this chapter. Okay, so chapter 18, Biopsychology of Psychiatric Disorders, the Brain and Hinge. So when we mean and Hinge, meaning something to do with unbalanced or deranged or a particular problem with with a certain behavior, or somehow, since this is biopsychology, we might be able to associate it to the brain parts. Now, um, defining psychiatric disorders is fairly straightforward. So, psychiatric disorder or psychological disorder is somehow a disorder of psychological functions sufficiently severe to require treatment by a specialist or expert or a psychiatrist, medical uh, professionals, or clinical psychologists, and explaining how these disorders differ from the psychological disorders, which is somehow difficult at first to determine whether there is really or no clear-cut differences between the two types of such disorder. And psychiatric disorder is basically uh, diagnosis is guided by the DSM, or the Diagnostic Statistical Manual of the American Psychological Association. So the convention of viewing psychological disorder is being of two fundamentally different types: psychiatric or neuropsychological. So it is the product somehow of the archaic mind brain, the psychology and biology dichotomy. So this was also thoroughly discussed, no, by the one or the teacher, the professor who was assigned to discuss in chapter 2 as well. And neuropsychological disorders are those that were assumed to be products of dysfunctional brains. The term neuro, it's something to do with the brain. And psychiatric disorders are those, no, that were assumed to be products of dysfunctional minds in the absence of brain pathology, which you will be learning this in this particular chapter. Now, common psychiatric disorders, there are actually four, okay, four disorder that will be covered here in the psychiatric disorder chapter. So we have the schizophrenia, the affective disorders, anxiety, and the Tourette syndrome. So schizophrenia is somehow a splitting, a splitting of psychic functions. So the term was coined in the early years of the 20th century, which to describe what was assumed at the time to be the primary symptom of the disorder. And this is actually refers to the breakdown of integration of emotion, thought, and action. Okay? So schizophrenia is actually the disease that is most commonly associated with the concept of madness. And it attacks somehow about 1% of individuals of all races and cultural groups. And some of this usually develops or begins in adolescence or early adulthood. And schizophrenia occurs in many forms. Okay? And they are actually, as I mentioned, uh, symptoms of such schizophrenia is delusions, common symptoms, hallucinations, odd behavior, incoherent thought, and inappropriate affect. So these are most common symptoms of schizophrenia. And there are also etiological and causative factors, which we'll be able to discuss also in this chapter about schizophrenia. Um, So there are certain symptoms again and of schizophrenia as a result, no, of certain studies or research conducted and even classified in the DSM-5 that there are following or common symptoms of schizophrenia, but not actually none all of them appears in all cases in a certain individual. So indeed, the recurrence of only one of these symptoms for 8 months is ground for the diagnosis of schizophrenia. So when we mean bizarre delusions, so it's somehow associated with uh, delusions of being controlled. Okay, example, okay, making somehow think of evil thoughts. Okay, and then delusions of persecution, like a very clear example is when this statement goes, "My mother is trying to poison me." Okay, this is a simple statement of implicating delusions, symptoms, and delusions of grandeur, because there are certain levels of or type of delusions. The delusions of grandeur is somehow associated with a simple statement again. Michael Jordan admires my sneakers. Okay, so it's a clear indications of being powerful, okay, or being known. So another is inappropriate affect. So failure to react with an appropriate level of emotionality to positive or negatively on the person's behavior. And another presentations or symptoms is of schizophrenia is incoherent thought. So when we mean incoherent thought, there is illogical thinking, peculiar associations among ideas, or belief of supernatural forces, okay, leading to hallucinations. Or when we say hallucination, there is an established imaginary voices telling the person what to do or commenting negatively on the person's behavior. And odd behavior is long periods with no movement. So when we mean no movement, this is common on schizophrenia who are catatonia, okay? Catatonic reactions, which is a lack of personal hygiene, talking in rhymes, avoiding social interaction, and at the same time, echolalia. When we say echolalia, meaning repeating words which they heard, okay? Repeating words whenever they heard someone or person talking. So like parroting, okay? Now, the causative factors of schizophrenia or the etiology of schizophrenia is presented in the following um, mm, evidences. So it's in the first half of the 20th century wherein the cloak of mysticism began to be removed from mental illness by a series of studies which are actually established uh, that schizophrenia's genetic basis. First, so it's evidence for a genetic contribution. And this is somehow uh, discovered that although only 1% of the population develops schizophrenia, the probability of schizophrenias occurring in a close biological relative, for example, in parent, child, or sibling, of a schizophrenic is about 10%, even if the relative was adopted shortly after birth by a healthy family. So, um, then it was discovered that the concordance rates for schizophrenia are higher in identical twins. Okay, so there are 45% than in the fraternal twins, which is only 10% in comparisons to identical. So this was presented or studied by Holzman and Mathis in 1990. And Coleman, Coleman in 1946 at the same time. And the studies were adopted and shown that the risk of schizophrenia is actually increased by the presence of disorder in the biological parents, but not by its presence among adoptive parents, because there's no blood connection when we mean adopted, unless the adopter or the adoptive parents are somehow dunay relationship or blood relationship like aunt or whatsoever. Okay, so the fact that concordance rate for schizophrenia is identical twins, which is somehow substantially less than 100 percent, suggested that differences in experience somehow also contribute significantly in the difference among people in the development or in the effect of schizophrenia. So the current views is that people inherit a potential for schizophrenia. Okay. So another is schizophrenia. Another causative factor is so clear that schizophrenia has multiple causes. Okay, and there was studies conducted by Kennedy et al. That regions on several different chromosomes have been implicated in the vulnerability of schizophrenia. So also, a variety of early experiential factors have been implicated also in the development of schizophrenia. For example, early infections, okay, which somehow affected among individuals, autoimmune reactions, okay, uh, what else? Toxins, okay, exposure to toxins or any chemical uh, um, affecting certain individuals, or for instance, children. Okay. Traumatic injury, these are also okay somehow considered associated causes of schizophrenia. And stress, which is somewhat an underlying causes of schizo. So these early experiences are thought, to alter the normal course of the neurodevelopment, leading to schizophrenia in the individual with genetic susceptibility. Okay? So interference with the normal development of susceptible individuals may lead to the development of such disorder. Okay, now there are certain drugs which somehow being discovered in order to at least mitigate or treat schizophrenia. And some of these drugs are somehow effective, and but it could not be considered a lifelong effect. There is just an immediate effect found to be effective at the early stage, but somehow it could not be considered a persistent or lifelong intake medication. I mean, uh, not a lifelong treatment. No? So, discovery of the first anti-schizophrenic drugs, or we term this antipsychotic drugs. So, the first major breakthrough in the study of the biochemistries of schizophrenia was the accidental discovery in the early 1950s of the first antipsychotic anti-schizophrenic drug, which is the chlorpromazine. Now, chlorpromazine was developed by a French drug company, and this is considered as antihistamine. In 1950, a French surgeon noticed that these drugs or chlorpromazine given prior to surgery in order to counteract swelling. Um, and this swelling had a calming effect on some of these patients. So therefore, he suggested that it might have a calming effect on difficult to handle psychotic patients, as he thought. No? His suggestion proved to be incorrect. Okay? Remember, chlorpromazine calms many agitated schizophrenics and activates many emotional blunt schizophrenics. Why consider that such suggestion of a French surgeon was incorrect? But the research triggered led to the discovery that chlorpromazine alleviates schizophrenic symptoms. Okay, so when we mean alleviate schizophrenic symptoms, that's somehow immediate respond to chlorpromazine is to calming effect, no, of the agitated schizophrenics. Um, and somehow emotionally blunted schizophrenics were activated by it. Okay, so it will activate more on the blunted schizophrenics. So it doesn't. No, don't get the idea that chlorpromazine actually cures schizophrenia. Okay, as I mentioned a while ago, it is just an immediate mitigations that somehow alleviates, no, this particular symptoms. Okay, but it won't be considered. I mean that this will totally cure schizophrenia. It doesn't. But in many cases, it reduces the severity of schizophrenia symptoms or schizophrenic symptoms enough to allow institutionalized patients to be discharged then and continue taking such medication regularly. Now, shortly after the anti-schizophrenic action of this drug, chlorpromazine, was being documented or discovered, another American psychiatrist somehow became interested in reports that this particular snake root plant had long been used in India for the treatment of mental illness is what we call the reserpine. And they found this also to be effective, but somehow no longer used. So the active ingredient of the snake root plant, reserpine, this will help schizophrenic patients and confirm its anti-schizophrenic action. Reserpine is no longer used in the treatment of schizophrenia. Why? Because although it was introduced and they found it effective, same with chlorpromazine in the early stage, but they no longer used it in the treatment of schizophrenia because it produces somehow a side effect, a dangerous decline in blood pressure at the doses needed for the treatment. So although the chemical structures of chlorpromazine and reserpine are dissimilar, their anti-schizophrenic effects are similar, at least in two ways. Okay, they are similar in terms of its effect. Okay, in two major respects. First, the anti-schizophrenic effect of both drugs is manifested only after a patient has been medicated for 2 to 3 weeks. Second, the onset of the anti-schizophrenic effect of the medication is usually associated and affected more on the motor effects similar to the symptoms of Parkinson's disease. So, what are some common uh, symptoms of Parkinson's? What you have observed, okay, with Parkinson's disease? So, actually, there is such thing as tremors, no? Tremors, even they are at rest. And there is an indications of muscular rigidity and a general decrease in voluntary movement. So these similarities suggested that chlorpromazine and reserpine were acting through the same mechanism, one that was to the Parkinson's disease. Okay. Now, what's the theory of dopamine theory of schizophrenia? How this dopamine somehow alleviates or help schizophrenia, psychiatric problem. So it was in paradoxically, the next major breakthrough in the study of schizophrenia came from the research on Parkinson's disease. So it was in 1960 when reported that the striatum, so striatum plus is a caudate plus butamins of a person. It's something to do located or something affecting a certain part, no, of the brain part of associated with Parkinson's disease. So stratums of the persons dying of Parkinson's disease has been depleted. So meaning depleted of this particular transmitter, neurotransmitter, which is dopamine. This finding suggested that a disruptions of dopaminergic transmission might produce, so it disrupt, no, may disrupt ang dopamine transmission, which is the dopamine neurotransmitter, uh, might somehow produce Parkinson's disease. And because of the relation between Parkinson's disease and the anti-schizophrenic effects of chloropromazine and reserpine, also suggested that anti-schizophrenic drugs effects might be produced in the same way. So, thus, dopamine theory of schizophrenia is caused by too much, or this is the association, too much dopamine, and conversely, that anti-schizophrenic drugs exert their effects by decreasing dopamine levels. Okay. So these are important theory behind dopamine for schizophrenia. So again, it's the theory that schizophrenia is caused by too much dopamine, and conversely, that anti-schizophrenic drugs exert their effects by decreasing dopamine levels. So meaning, antipsychotic drugs side effects suggest role for dopamine. Drugs work by decreasing dopamine levels. Okay. And schizophrenia is associated with dopamine overactivity. So, reserpine depletes brain of dopamine and other monoamines by making vesicles leaky. A. Now, what's the role again of uh, monoamines and cocaine, which are considered, um, which they are considered as dopamine agonists and produce psychosis. Okay. Now, as we continue, before we further discuss about the role of these uh, drugs, amphetamine and cocaine, as agonists, um, so chlorpromazine antagonizes dopamine activity by binding and blocking dopamine receptors. So, um, first, the antipsychophrenic drugs, as anti-schizophrenic drug, reserpine was known to deplete the brain of the dopamine and other monoamines by leaking down their synaptic vesicles. Second, drugs such as amphetamine and cocaine, which we emphasize, no, mm, can trigger schizophrenic episodes. They can trigger schizophrenic episodes. No? So dopamine agonists and produce psychosis. So they can trigger schizophrenic episodes in normal subjects and increase the extracellular levels of dopamine and other monoamines in the brain. So the importance of dopamine uh, in the evolution of dopamine theory of schizophrenia actually came in 1963 when Carlson and linguists assessed the effects of chlorpromazine on extracellular levels of dopamine and its metabolites. So when we say metabolites, these are molecules that are created when another molecule is broken down. Okay? So the extracellular levels of dopamine were unchanged by the chlorpromazine, and the extracellular levels of its metabolites were somehow increasing. Okay. So the researchers then concluded that both chlorpromazine and reserpine somehow antagonize. Okay, they antagonize transmissions at dopamine synapses, but somehow they differ that in different. They do it in different ways. So in the case of the reserpine, okay, uh, depleting the brain of the dopamine, depletes brain of the dopamine, and once depleted the brain of dopamine, chlorpromazine binds to the dopamine receptors on the other hand. So Carlson and linguists somehow argued in this particular phenomena, okay, that chlorpromazine is a receptor blocker at dopamine synapses and it binds to dopamine receptors without activating them. So if you have seen your book, no, Pinel, in figure 18.1, you can see a structure there. Somehow gives us an idea how these particular neurotransmitters and chemicals uh, block the receptors of the dopamine. So now, in general, they found that chlorpromazine and the other effective anti-schizophrenic drugs had a high affinity for dopamine receptors, whereas ineffective anti-schizophrenic drugs had a low affinity, meaning when we say low affinity, low connections or relationship. So there were, however, several major exceptions One of them being the so-called haloperidol. These are common drugs class actually, given to those who are having psychotic features, or they are mostly given to psychotic patients. Okay? So haloperidol was one of the most potent anti-schizophrenic drugs of its days, and it has a relatively low affinity for dopamine receptors. Okay? Now, it turns out that going back to chlorpromazine and the other anti-schizophrenic drugs in the same chemical class, another, which is the phenothiazines, bind effectively. Okay? They bind effectively to phenons, no? They bind effectively to both dopamine 1 and dopamine 2 receptors. Whereas the haloperidol and the other anti-schizophrenic drugs in its chemical class, like the phenons, they actively bind to the dopamine 2 receptors, but not to the dopamine receptors 1. Okay, so take note of that. In general, uh, the affinity, the higher affinity a drug has for dopamine, um, okay, in the higher affinity a drug has for dopamine receptors, the more effective it is in treating schizophrenia. And this haloperidol is an exception. Why? Because most antipsychotics bind to D1 or dopamine 1 and dopamine 2 receptors, and the other butyrophenons bind to D2. Okay. Now, how about uh, associating the neural bases, no? Associated uh, schizophrenia associated with brain damage. So, well, it has a little damage to dopamine circuitry, as researches are being considered in the study in this particular chapter. Okay, so so how does it associated with brain damage? Brain imaging studies of schizophrenic patients typically reveal widespread abnormalities, even or including an abnormally small cerebral cortex and abnormally large cerebral ventricles. However, although the brain damage is widespread, it is not actually or not evenly distributed. For example, cortical damage is most prevalent in the prefrontal, the cingulate part of the brain. And of course, schizophrenia associated with brain damage could not be explained by dopamine theory. So, two things about the pattern of brain damage observed in many schizophrenics are problematic for the dopamine theory because it is not somehow associated with it, cannot be explained. One is that there is a little evidence of structural damage to dopaminergic circuits. Okay? The other is that the dopamine theory provides no rationale for the diffuse pattern of brain damage that is often observed among schizophrenia patients. So many other chemicals or neurotransmitters that are somehow helpful, neuro or chemical substances or that's somehow helpful, no? for schizophrenics is neuroleptics. Okay? So neuroleptics drugs. Okay. So much more with schizophrenia. Let's go to affective disorder, which is another uh, category of psychiatric disorders. Out of the four, there are four. So we tackled about schizophrenia, and now let's focus on affective disorder, which is associated or somehow associated with depression and mania. Okay, so all of us have experienced depression, though some of us experience uh, mild depression, and others also experience severe depressions. It depends on how we are being exposed to a particular stresses in life. So depression is a normal reaction, okay, to grievous loss, to grievous loss such as the loss of a loved one, the loss of our own self-esteem, okay, and even the loss of personal possessions, which we really valued entirely of our lives, or the loss of health. Now, however, there are people whose tendency toward depression is out of proportion. Okay? They could hardly manage or they could hardly control themselves with those depressive experiences that they have gone through. So, in such a way that it loses, um, it's already now out of proportion in responding to such stress. So, these people repeatedly fall into the depths of despair and lost the capacity, okay, lost the capacity to experience the pleasure. And they often, for no apparent reason, their depression can be so extreme that it is almost impossible for them to meet the essential requirements of their daily lives. So it will now affect their day to day activities or their normal functioning and their uh, significant functioning in their work, in their community, or even in their homes, in their jobs, or in their responsibilities. So to keep a job, to maintain social contacts, or even to maintain an acceptable level of personal hygiene is already somehow uh, affected. So it is these people who are said to be suffering from clinical depression. Okay? So depression, again, is normal reaction to loss, abnormal when it persists or has no cause. And mania, somehow opposite to depression because it's a feeling of overconfidence, impulsivity, distractibility, and high energy. So there are major categories of affective disorders. So depression is not the only affective disorder, take note. Okay? So it's a psychotic disorder of emotion. The other major type is, as I mentioned, it's mania, which is in many respects the opposite of depression, of course. Mania is an affective disorder also, which is characterized by overconfidence, which I emphasize a while ago. So during these periods, or during periods, I mean, of mild mania, actually people are talkative. They are energetic, they are even impulsive, positive, and very confident. In this state, they can still be very effective in certain jobs, and they can be great fun to be with. But when mania becomes extreme, it is a serious clinical problem already. or it will develop a serious clinical problem. The florid manic often awakens in a state of unbridled enthusiasm with an outflow of incessant chatter. So, non-stop from topic to topic, sige lang storya, sige lang og storya nga walay katapusan. Okay? So, this confidence and grandiosity, coupled with high energy, destructibility, and a leap before you look impulsiveness, result in a continual series of disasters. And mania often leaves behind in a trail of unfinished, usually mura sila sudden ebb and a sudden flare of fire. Gusto trabaho, pero gusto himuon dayon, gusto very kuan kayo, impulsive, and later doesn't want to finish it. So unfinished projects, unpaid bills, and broken, some result to broken relationships. Okay. So um, okay. Many depressive patients experience periods of mania. Okay. It could either be uh, those who suffered from either bipolar or unipolar, or reactive and endogenous. So those who do are said to suffer from bipolar affective disorder also experience periods of mania. Those depressives who do not experience periods of mania are said to suffer from unipolar affective disorder. Take note the difference. Depressive patients experience periods, those who experience periods of mania are suffering from bipolar affective disorders. But those who experience unipolar affective disorder are persons who do not experience periods of mania. So depression now is divided into two categories. Depression triggered by a negative experience, example, the death of a friend, a loss of a job, and these are considered reactive depression. Okay? So these are falling under types. These are types of depression. Versus endogenous. So these are depression with no apparent cause at all. So the high incidence of affective disorders in industrialized countries or cities or societies, Western societies, has been well documented. And it was found out that there are most likely 6% of the people suffer from unipolar affective disorder at some point in their lives. And somehow, um, somehow 1% uh, suffer, okay, 1% suffer from bipolar affective disorder. So unipolar affective disorder tends to be twice as prevalent in women, no, as in men. But there is no sex differences in the incidence of bipolar affective disorder. So about mga 10% based on the study of those suffering from affective disorders resulted or committed suicide. So genetic factors is concordance rate higher to bipolar than unipolar. Okay. Now try to go over what are the etiologies or the causative factors again. It's genetic in nature. So it's the factors contributed to the difference among people in the development of AD or affective disorder. So, even twin studies of affective disorders suggest a concordance rate of 60%. 60% of uh, identical twins and 15% for fraternal twins, whether they are reared together or even apart from each other. Although there are many exceptions, there is a tendency for affected twins to suffer from the same type of disorder. Unipolar might either be unipolar or bipolar. And the concordance rates for bipolar disorder tends, as I mentioned again, higher siya than those for unipolar disorders. Most of the research on the causal role of experience in the affective disorders focuses on the role of stress, no, as the etiology or the causative factors of depression. And several studies have shown also that stressful experiences can trigger attacks of depression, uh, uh, experienced already by depressed individuals. Okay, now, so again, it's stressful experiences, evidence linked to stress and affective disorders. Extreme stress is more likely to cause PTSD, depression, or post-traumatic stress disorder or depression. And we also have the so-called SAD or the seasonal affective disorder. It's associated with the climate, time, depression, and lethargy. So most likely affects no sa unsay it will also be associated or uh, on the climate or on the seasons time usually experience. So let's go through the discovery of antidepressant drugs. So what are the common okay, common antidepressant drugs? Four major classes of drugs are used in the treatment of this affective disorders. We have the monoamine oxidase inhibitors, the tricyclic antidepressants, lithium, and the selective monoamine reuptake inhibitors. Now let's take these monoamine oxidase inhibitors or the iproniacid. It prevents breakdown of monoamines. And most avoid foods high in pyramine. So cheese effect. Okay, now. So in this monoamine oxidase inhibitors or the iproniacid, the first antidepressant drug originally developed by the treatment of tuberculosis. And it was proved to be a dismal flop, okay, because interest in the antidepressant potential of the drug was linked or kindled by the observation that it left patients with tuberculosis less depressed about their disorder. So, no connections. As a result, iproniacid was tested on a mixed group of psychiatric patients and was found to be effective against depression. It was first marketed as an antidepressant drug in the year 1957. So iproniacid is a monoamine agonist and it increases the levels of monoamines. So unsa man mga example yung mga neurotransmitter norepinephrine and serotonin. So Sila ang inhibit sa activity sa monoamine oxidase or the so-called MAO. So MAO, which the enzyme that actually breaks down, if you still recall your uh, neurotransmitter or the chapter that discusses about certain uh, neurochemical transmissions or neural conductions and synaptic transmission. If you still recall in that particular chapter of chapter 4, okay, so this is somehow a continuous uh, emphasis on the role of the monoamine oxidase as an antidepressant drugs. So now again, going back, the enzyme breaks down monoamine neurotransmitters in the cytoplasm sa neurons. Okay? MAO inhibitors then have several side effects. The most dangerous there is known as the cheese effect. So why? Why? What's in the cheese? It's a food such as cheese, wine, and pickles contained an amine called tyramine, which is the potent elevator of blood pressure. So, muna nga ang cheese, too much intake of cheese, sige kaon, especially for mga taas of pressure, the more it will heighten blood pressure. Okay? Because tyramine is rapidly metabolized in the liver by the MAO or the monoamine oxidase. However, people who take MAO inhibitors and consume tyramine rich foods run the risks of stroke, which somehow caused by surge in the blood pressure. Take note of that. Okay? Now, another is the tricyclic antidepressants, or which is somehow termed as imipramine, imipramine, or block reuptake of the serotonin and the norepinephrine. Mas safer siya if you compare it to the MAO. Why? These tricyclic antidepressants are so named because of their antidepressant action and because their chemical structures include three rings of atoms. So the imipramine, the first tricyclic antidepressant, was initially thought to be an antipsychophrenic drug. However, when its effects in a mixed sample of psychiatric patients were being evaluated or being assessed, its antidepressant effects was immediately clear, so obvious. So, therefore, the tricyclic antidepressant somehow block, no, the reuptake of both neurotransmitter norepinephrine and serotonin, and it will now increase their levels in the brain, causing it much more safer alternative to MAO inhibitors. Now, the other chemicals involved is lithium. Lithium is simply class. The discovery of the ability of this lithium is a simple metallic ion, or black mania is yet another important pharmacological breakthrough, okay, that was made or studied. It is known to be a mood. Unang use gamit ni siya kayo ron, murag siya ang mas overuse gamit or mas somehow most likely tanang i-prescribe sa mga psychiatrists, no, for bipolar disorders. So lithium is considered to be a mood stabilizer, a drug that blocks the rapid transition between depression and mania rather than treating depression. So dili na siya ingon um, throughout mo treat siya no, sa schizophrenia. It will just somehow um, uh, na lang siya ay blockage of such rapid transition from the depression to mania. If until this recent study, lithium was the treatment of choice for bipolar affective disorder. And supplanted by mood stabilizers, which are effective against depression. Now, so let's proceed with SSRI, or the selective monoamine reuptake inhibitors. So uh, common are Prozac, Paxil, Zoloft, and others. Okay. So actually, tricyclics is more effective than the rest of the four mentioned antidepressant drugs. Side effects are somehow few, and they are effective in treating other disorders as well. But considering the SSRI, it was in the late 1980s when this drug, selective serotonin reuptake inhibitors, was introduced for treating depression. It exerts agonistic effects on the serotonergic transmission by what? By blocking, no? By blocking the reuptake serotonin from synapses. If you have observed here, serotonin, vesicles, makita ninyo yung mga structure, and these are the receptors here in the presynaptic, and then Prozac blocks and reabsorbs, okay, the serotonin. So fluoxetine, which is marketed as Prozac, fluoxetine, was the first SSRI to be developed. And now, daghan na kairon, na naanggit gingon na Paxil, Zoloft, Lovox, Remeron. So, these are actually common kanang mga treatment, no? Pharmacological treatment, usually uh, ihatag sa mga sa mga psychiatrists for psychiatric and psychotic patients. So now there are many. No? Prozac structure is a slight variation of that imipramine and other tricyclic antidepressants. In fact, class, the Prozac is no more effective than imipramine in treating depression. Uh, the remarkable popularity of Prozac and other SSRIs is attributable to two important things. First, they have few side effects. Second, they are effective against a wide range of psychological disorders, in addition to depression. Because SSRIs are so effective against disorders that were once considered to be the exclusive province of psychotherapy. Sa man mga kasagaran ng mga problem, lack of self-esteem, fear of failure, excessive sensitivity to criticism, low kayo tolerance level, and the inability to experience pleasure. They have had a major impact on psychiatry and clinical psychology. So the success now of SSRI spawned into the introduction of other similar class of drugs. We have the so-called selective norepinephrine reuptake inhibitors, or the SNRIs. The SNRIs. And So example of this are reboxetine. They have proven to be as effective as the SSRIs in the treatment of depression. Also effective against depressions are drugs, which somehow block the reuptake of more than one monoamine neurotransmitters. So effectiveness of drugs actually class in the treatment of depression somehow involves on these three, four important neurotransmitters, but the results were about the same for the MAO inhibitors, tricyclic and the antidepressants, uh, SSRI, monoamines, no? 5% of depressed subjects improve compared to the 25% of the placebo controls in the study. So although all three categories of drugs benefit some patients experiencing attacks of depression, they seem to have little or no effects with regard to prevention of the recurrence of attacks. So, so let's discuss on the brain pathology and the affective disorders. Hmm. So this is an inconclusive evidence for reduction of size of the brain for individual components due to bipolar affective disorder based on the MRI, okay, imaging instrument or data. So you can observe here that there's a remarkable change or a decaying part of the brain, the shrinkage of the amygdala, cingulate cortex, and the prefrontal cortex. So, as in terms of the pathology of the affective, individuals diagnosed with depression display damage to many parts of their brains. It's really associated with it. However, damage is most frequently observed in three areas. Now, these three areas are the amygdala and the prefrontal uh, cortices. Um, they play a role in the perception and experience of emotion. And the third area comprises several of the terminal sites of the mesotelencephalic dopamine system. Okay? So somehow it is involved in the experience of pleasure because depressed patients often suffer from anhedonia. So what is anhedonia, class? Anhedonia is the inability to experience pleasure. It is not surprising then that they would display abnormalities in the striatal and limbic structures of the mesotelencephalic dopamine system. So it was discovered that made possible by brain imaging technology, as I mentioned. The, the structure changes in the brain of the patients with unipolar affective disorder. And you can observe here how there is a shrinkage of certain structure of the part of the brain, which especially amygdala and other cingulate cortex and prefrontal cortex. So that's why uh, it's associated that there is problem experience of pleasure. Um, Depressed patients often suffer from anhedonia or inability to experience pleasure. Okay? Because of associations with brain pathology on the affective disorders. So na close knit no affinity with the affective disorder to the brain structure problem. So now let's have this so-called diathesis stress model of depression. We focus on diathesis is equals to genetic susceptibility. It's when it is added with stress, it results now, it is equal to depression. Supports is indirect. For depressed people, they tend to release more stress hormones. Okay? They fail dexamethasone suppression test. They failed. Normal negative feedback on stress hormones not functioning in many depressed patients. Um, so diastasis is actually uh, when we mean genetic susceptibility, incapable of initiating the disorder by itself. So the central idea of the diastasis stress model is that if susceptible individuals are exposed to stress early in life, of course, they become permanently sensitized and they overreact to mild stressor for the rest of their lives. Support for the diathesis stress model of depression is largely indirect. Okay? It is based on the finding that depressed people tend to release more stress hormone. Okay? Um, so, moreover, inter injections of dexamethasone, which is a synthetic glucocorticoid do not reduce the release of glucocorticoids through negative feedback in many depressed patients, though they do somehow in normal subjects or patients. Now, common treatment for depression with brain stimulation. So it's in the 2008 study that chronic electrical stimulation near the anterior cingulate gyrus help relieve depression in treating resistant patients. So it's somehow uh, a uh, very interesting study to consider in determining treatment of depression through brain stimulation. So it's in the 2008, but somehow there are also uh, pharmacological treatment right now which has same effect with that electrical stimulation, affect treating the anterior cingulate gyrus in order that a resistant patient will be somehow alleviated and relieved with their depressive feelings. Yeah. So, so much so with affective disorder. So let's proceed to anxiety disorder, which is the third disorder which we are going to consider. Anxiety is just plain and simple a chronic fear in the absence of threat or any direct threat. And it is common psychological correlate of stress as well. And it is adaptive if it motivates effective coping behaviors. However, when it becomes so severe that it will now disrupt the normal functioning, then it is considered now anxiety disorder. All anxiety disorders are associated with feelings of anxiety, such as fear, worries, despondency, and with a variety of physiological stress reaction, for example, tachycardia, which is a rapid heartbeat, hypertension, of course, high blood pressure, nausea, so breathing difficulty, sleep disturbances, and high glucocorticoid levels. So there are certain classes, no, emphasize here uh, five classes of anxiety disorders, which was also associated in the DSM 5. So we have generalized anxiety, um, phobic anxiety disorders, panic disorders, OCD, obsessive compulsive disorders, and post traumatic stress disorder. So there are five again, and generalized anxiety disorder is actually characterized by stress responses and extreme feelings of anxiety that occur in the absence of any obvious precipitating stimulus. On the other hand, phobic anxiety disorders are similar to GAD or generalized anxiety disorder, except that they are triggered by exposure to particular objects, such as like birds, spiders, or certain situations. Example, crowds or darkness. So like mga agoraphobia. Panic disorders are characterized by rapid onset attacks of extreme fear and severe symptoms of stress. So what usually experience choking, heart palpitations, shortness of breath. Okay? So they are often components of generalized anxiety disorders and phobic disorders also. But they also occur as separate disorders. And obsessive compulsive disorders or OCD, they are characterized by frequently recurring uncontrollable anxiety producing thoughts. So that is producing thoughts of obsession, and it is accompanied with impulses, compulsions. So responding to them, for example, like repeated compulsive hand washing, okay, as means of dissipating the anxiety associated with them. Okay, checking. Okay. Then the other one is post-traumatic stress disorder or PTSD. It is a persistent pattern of psychological distress. Now, these are somehow following exposures to extreme stress. Okay, what is now then? Let's proceed to the etiology of anxiety disorder. Of course, again, it is genetic evidence for genetic or heritability, and its role of life experiences, which somehow they're exposed to or triggers their um, stresses or their experiences in the painful experiences in the past. Because anxiety disorders are often triggered by identifiable stressful events, and because the anxiety is often focused on particular objects or situations, the role of experience, it is accompanied with experience, in shaping the disorder is often readily apparent. Okay. So, unlike other psychiatric disorders, anxiety disorders have a significant genetic component. Okay. The concordance rates for various anxiety disorders are substantially higher for those identical twins than for fraternal twins. Although identical twins have the same genetic susceptibility to anxiety disorders, the timing and focus of their attacks often reflect their individual experiences also. Okay, bisa na sila connections or na sila genetic susceptibility to get sila. But it will somehow be triggered or the attacks will differ in terms of their individual experiences. Okay, what are now then some pharmacological treatments of anxiety? So let's try to consider common. Okay, we have benzodiazepines. So it's somehow considered common mga genetic kay nga pharmacological um, substances is Librium and Valium. They also use as hypnotics, anticonvulsants, and muscle relaxants. Now, so benzodiazepines such as chlordiazepine, chlordiazepoxide, or Librium. So the other term no for Librium. So I don't confuse yourselves with those scientific term anymore. So just directly go to Librium and Valium. But somehow chlordiazepoxide is Librium and diazepam is Valium. Okay, mas common ang diazepam. They are widely prescribed for the treatment of anxiety disorders, and they are also prescribed as hypnotics, sleep-inducing drugs, anticonvulsants, and muscle relaxants. So, benzodiazepines are mostly prescribed psychoactive drugs. Approximately 10% of those Western adult Americans are currently taking those medications. But somehow, class, there are certain side effects also. Sedation, usually, side effects of benzodiazepines are sedation, ataxia. When we mean ataxia, it's something to do with the disruption of motor activity. Then tremor, nausea, addiction, and a withdrawal reaction that includes rebound anxiety. Another serious problem with benzodiazepines is that they are actually addictive. Mo addictive na sila class. So therefore, there must be psychiatrists usually or consequently prescribe only for short-term purposes. The behavioral effects of benzodiazepines are thought to be mediated by their agonistic action sa gamma aminobutyric acid agonist receptors. So kung i-bind gani ang benzodiazepines to GABA A receptor at a different site than the one of which GABA molecules bind, in so doing, they increase the binding of GABA molecules to the receptor. And these GABA A receptors were actually distributed widely throughout the brain. And then we have the serotonin agonists. So most common is buspirone or the SSRI. They are widely used for treating anxiety disorders. For example, okay, this so-called buspirone often prescribed for the treatment of anxiety, and they have selective agonist effects of one subtype of serotonin receptors. So the main advantage of buspirone class over the benzodiazepine is its specificity. It produces anxiolytic anti-anxiety uh, effects without producing ataxia. Bisan walay ataxia, walay uh, problem with problem or disruptions of certain motor functioning activity. So buspirone does, however, have other side effects: dizziness, nausea, headache, and insomnia. Okay. So, serotonin agonists that are used to treat depression, katong mga monoamine oxidase, tricyclic antidepressants, and selective serotonin reuptake inhibitors, tend to have anxiolytic effects. No? Ano sila yung mga anxiolytic effects or an anti-anxiety effects. And somehow, SSRI are also commonly used in the treatment of anxiety disorders. Is there any uh, neural connections of anxiety, neural basis of anxiety? Of course, there is. Drugs suggest a role for serotonin and GABA. Now, it's the amygdala, due to its role in fear and defensive behavior, thought to be involved. Okay? But so far, um, no obvious structural pathology yet identified. Naka-specific yet. But somehow that part sa amygdala is affected. Like current theories of the neural basis of schizophrenia and depression, neural basis of anxiety rest heavily on the analysis of therapeutic drug effects. Okay? Uh, Considering the fact that many anxiolytic drugs are agonists of either GABA A receptors. Okay. So much so with anxiety. Let's proceed now to if you can observe the certain structures of the brain affecting whenever a person suffers from generalized anxiety disorder. Either there is hyperactivation of the brain parts, amygdala, or there is hypoactivation. Okay? And then deactivated or activations of the brain with response to anxiety disorder. So now let's proceed to the last psychiatric disorder, common psychiatric disorders, which is the Tourette syndrome. Tourette syndrome is a disorder of tics. Okay. It's a disorder of tics. When we mean tics, it's involuntary movements or vocalization. And somehow, It is typically begins in childhood with simple motor tics such as eye blinking or head movements. But the symptoms develop over time, becoming more complex and somehow severe. Common complex motor tics include making lewd gestures, hitting, touching objects, squatting, hopping, twirling. So common verbal tics include, so that's movement. So with response to uh, verbal tics include inarticulate sounds, example barking, coughing, grunting, or coprolalia. What is coprolalia? It's uttering obscenities. Or echolalia, the repetition of another's words. And the palilalia, the repetition of one's own words. What's the difference of echo and the palilalia? Echo is something a person or a patient hears what others saying. So iyang i-parrot, iyang i-repeat. But palilalia is a person mismo na unsa iyang isulti balik-balikon, balik-balikon. So mura siya ga murmuring. So this Tourette syndrome developed in approximately 0.7% of children, and it is 3 times more frequently, in males than females. So there is a major genetic components, concordance. Uh, Rates are 55% sa identical twins and only 8% for fraternal twins. Um, some patients with Tourette syndrome also display signs of attention deficit. So it's also associated mostly with signs of ADHD or attention deficit and hyperactivity disorder or OCD, okay, obsessive compulsive disorder, or even both of that. So, although the acts of Tourette's tics of Tourette syndrome are involuntary, they can be suppressed for brief periods of time with great concentration and, of course, effort from the patient. Okay? If they will undergo therapy as well. So, and it is associated that patients with Tourette's tend to have smaller caudate nuclei, part subbrain structure. Now, what are the common treatment of Tourette? Usually treated with neuroleptics, although effectiveness is not well established yet. Although tics are the defining feature of uh, Tourette syndrome, uh, treatment typically begins by focusing on other aspects of the disorder. First, the patient family, support members, friends, and teachers, and other educators that will educate them about the nature of the syndrome, para they are aware somehow. Second, treatment focuses on the ancillary emotional problems, example, anxiety and depression. Once these first two steps have been taken, attention turns to treating at least the symptoms. So the tics of Tourette syndrome are usually treated with neuroleptics, D2 receptors, with blockers that are used in the treatment of schizophrenia as well. And the apparent success of D2 blockers or D2 receptor blockers in the treatment of Tourette syndrome is consistent with the hypothesis that the disorder is related to the abnormality of the basal ganglia thalamus cortex feedback circuit. Okay? muna nga doon na siya yung mga involuntary movement. So in particular, the efficacy of this drug implicates the striatum, which is the target of the many of the dopaminergic projections into the basal ganglia in order that there will be diminishing or controlling uh, tremors or movement. So actually, another hypothesis of Tourette is current hypothesis is Storage syndrome is neurodevelopmental disorder that results from excessive dopaminergic innervation of the striatum and the associated limbic cortex. So, so much so, um, those are the four common psychiatric disorders mentioned with their corresponding uh, brain connections, neurotransmitters affecting depletion or oversecretions of such neurotransmitter in the particular sites of the brain affecting uh, problem behavior. So, and then the corresponding treatment as well that we have been discussing in this particular chapter. So, thank you and have a wonderful day, evening, and morning. God bless and continue taking care of yourselves.